Can you hear us?
Yes, yay.
Okay, I got her up and running here. She should be on. There she goes. All yours, Judy.
Perfect. Thank you.
I'm sorry.
No, it's okay. We
We're
totally understand tech difficulties.
Get on in another email. So, hello, everybody.
Hey. Do you want to introduce yourself and then I'll pull up your slides and you just take it away?
So, I'm Judy, and my last name is Germani, and I am a specialty care nurse coordinator. I work at Ruby. I work with Dr. Sokas. I worked with him for many years. We work with heart failure, the advanced heart failure patients, and pulmonary hypertension patients, and other patients that are thrown in there too. So, how is everybody today?
Pretty good. How are you?
I'm good. I was kind of sweating there for a minute, but I'm good.
No worries.
So today we're going to talk about dyspnea and primary care. So we can go on to the next slide. So we all know that dyspnea is defined as difficulty or labored breathing. And the American Thoracic Society defines dyspnea as a subjective experience of breathing. It's very not comfortable, and it consists of qualitative, distinct sensations that vary in intensity. And the next slide, please. So the mechanism of respiratory sensation is dealing with the efferent and the afferent systems. And it's what the brain does with the efferent, so with the motor output from the brain to the ventilatory muscles, and the afferent is what the receptors do with the inside the body and how the brain deals with it. So that's just a little background, which we all were taught that a long time ago. Next slide, please. So the etiology of dyspnea, it's really broad, and we have to really look at why the patient is telling us why they're short of breath. So it's actually cut down into 4 general categories: cardiac, pulmonary. It could be mixed cardiac or pulmonary, or non-cardiac or non-pulmonary. And you really stop to think about it. Yes, but that is so broad. So let's look at the next slide. So when when I was asked to talk about this, I was like, dyspnea. So what am I going to say about that? So this was my favorite thing, and I don't know how many people actually learned about this, the dyspnea pyramid, because I did not learn about this when I was in school. But I've been in school so many times, and but I did a little research on this. So, and there are YouTube videos out there about this. But the dyspnea pyramid is it's broken down into 4 sections: pulmonary, heart, and blood, and metabolic alkalosis and metabolic acidosis is for the top part of the pyramid. So let's look at the pulmonary. And when you think of pulmonary, when a patient says that they're short of breath, you think of all the P's. It's like asthma, COPD, that's pulmonary, but doesn't start with a P. The pulmonary pleural effusions, aspirations, hemorrhages, ARDS, PEs, pleural effusions, pneumonias, stuff like that. Of course, when you go to cardiac, here where I work, everybody thinks heart failure. When somebody calls with shortness of breath, people are like heart failure, but you really got to look at why they're saying they're short of breath and really listen to the patient. Cardiac tamponade, and the other side of cardiac, it could be an MI, it could be any arrhythmia. And then you have to think, are they anemic, no blood, or do they have bad blood? And then respiratory alkalosis and metabolic alkalosis. So if a patient is calling to say they're short of breath, And if you can look at their history, I'm sure they have more than one of these things going on. They maybe have a history of anemia, CAD, heart failure, recent pneumonia. So then they really throw you off. Then you ask some questions, and yes, they've had a 5 pound weight gain in the last month. So then the physician has to move forward with all that triage. So let's go to the next slide. So here, for heart failure, we judge our patients with NYHA classifications. So that is a New York Heart Association functional class, and that's actually what the patient can do. So it is just a simple way to classify them. The patient can change of what group they're in. It's groups 1 through 4, and it is based on what they can do. 1 is the best and 4 is the worst. And it can change. You can move forward and backward. Not many patients are in group 1, and it's just depending on their symptoms. But when you look at their office notes and you see that they were a class 2 and you see them 6 months later and they're class 3, then you can really judge on how they're doing with their heart failure, which is a great asset. So let's look at the next slide. And this is actually how the patient's symptoms are classified. So class 1 is mild. The physical activity is not limited at all. It doesn't cause any fatigue. Your heart rate doesn't get fast, and you're not short of breath. So actually, we're in a heart failure clinic today, and that's one of the questions I always ask the patients. Are you able to climb a flight of stairs without being short of breath? And there's not many times that the patient can say yes. A lot of patients will say they're short of breath bending over. A lot of people can be short of breath just talking. So moving on to class 2, they have a slight limitation of activity. They're comfortable at rest, but they do get tired easy and they're short of breath with minimal activity. Class 3, they get short of breath. They may be short of breath just doing minimal activity. They probably propping themselves up with pillows at night. And class 4 is somebody that's just sitting here in a chair like me, and they're short of breath talking. So that is shortness of breath for heart failure. If we can move to the next slide. Let's talk about a scenario of dyspnea. This is one of our patients that we had, and so our patient, he's 47 years old, and he has a history of ischemic cardiomyopathy. He also has a history of combined systolic and diastolic heart failure. So that's a little bit tricky because the diastolic heart failure is really hard to treat. But his EF is actually 10 to 15%. He's only 47 years old. He also has a possible LV thrombus. So he's been diabetic. He's type 2. He's also obese, which is another reason that you can be short of breath, carrying around a lot of extra weight. He's hypertensive. So, with COVID out there, we were doing a lot of telephone visits, the doctors, and video visits. So our one doctor did do a video visit with him, and he was showing him that how he gained weight. Swelling, I should say. He had swelling in his lower legs. But looking at this, he has a possible LV thrombus by echo, and he was on a blood thinner. I believe he was on Eliquis, and he said he did not miss any doses. So the patient did need to come into the office the next day and have an echo to see what's going on with him. The patient also said that he was, this isn't all on there because I couldn't fit everything on there, but the patient did say that he was using multiple pillows to prop himself up so he could breathe because he was short of breath, just sitting there. He couldn't lay flat at night to sleep. His JVD was elevated at 10 centimeters. And when he would walk, he would have shortness of breath. And he does have a history of CAD. So he did come into the office, and when I was talking to him, he said that his scale at home, all of our patients, we tell them to weigh themselves every day, and he said he had no changes on his scale at home. So the echo did show his EF was the same. He said that he did not change his eating habits. He did not have anything more salty or anything. He does not have a lot of income because he can't work. His wife works at a dollar store, so their income is not that high. So I don't know what their diet consists of fresh foods and everything. But the patient is on a blood thinner. He said he did not miss any of his Eliquis doses. So they did not believe that, he had any chest pain since he had a recent stress test within the last year or so. What happened, they believed that this problem was his weight gain related to his heart failure, increase his diuretic. And as a routine thing that we do in our heart failure clinic is increase the diuretic for about 3 days. Our nurses follow back up with the patient and see how the diuretic worked, if they lost all their weight or most of it, and to see how they're feeling. And if they didn't, we usually bring them back into the office, or if it doesn't work at all, the patient usually goes to the ER during those 3 days, and it always seems to happen on a weekend. I don't know why. So that is how that happened for this patient. So the next slide. So that falls into the heart failure and the dyspnea pyramid. The next slide, please. So heart failure can be caused by increased intracardiac pressures from LV dysfunction. And this person's LV dysfunction, his was ischemic cardiomyopathy. You can have increased left-sided pressures causing increased pressures inside the heart, and the pulmonary circuit causes increased shortness of breath. This patient that we just talked about also is obese, which was not helpful for him. It causes decreased cardiac output and poor LV function, which can result in poor activity levels and get really poor organ perfusion, resulting in worsening heart failure symptoms. When you have increased pulmonary pressures cause worsening right-sided heart failure and edema. Unfortunately for this guy, he's only 47 and he has a lot of marks against him, being diabetic, obese. He has kidney disease, and we're actually trying to move forward with transplant if he's agreeable. So just hoping he does well. So we have to keep up on these patients because sometimes they don't call us until they get really severe shortness of breath. Next slide. So another scenario is a patient, he's 60 years old. He has a history of a cough syncope. He has dyspnea on exertion, and trust me, this man did not exert himself very much because he couldn't. He does have anxiety, more likely related to his shortness of breath, essential hypertension, and CAD, which was very minimal. He was at the office. He had complaints of dyspnea. He was able to climb 4 steps before he became short of breath. He smoked a half a pack of cigarettes per day, and he really couldn't tell us how many years he was smoking, but he really did smoke for many years. Being 60, I think he was smoking much more, but he was not a good historian, and he was using smokeless tobacco too. His EF was 40 to 45%, and he had a right and left heart cath when he first came to see us, which just showed mild CAD. So when we see people with shortness of breath, and because we're using the diagnosis of heart failure and PH, pulmonary arterial hypertension, we think very broad. Does the patient have a pulmonary embolism? So we did send him for a V2 scan, which did show large areas of chronic thromboembolism in the left lower lobe. But we did send them for a chest CT, which did show no pulmonary embolism. And that's very confusing, but we can talk about that soon. He did have PFTs at another institution, so we did not repeat them. So the whole thing is this patient had COPD, and he just recently passed away. He went into hospice. Dr. Soka saw him. He went into hospice, but he had COPD. It was his main diagnosis. His secondary diagnosis was pulmonary hypertension. It was very sad. 60-year-old patient. The thing with him was he also had pulmonary arterial hypertension, and he came to us. The medicines from pulmonary arterial hypertension cause a lot of pain, and so he couldn't get a PCP because they were kind of labeling him as a drug seeker. He was on IV Remodulin for pulmonary hypertension. So we actually did not see that was the best medicine for him. And we were putting him on the inhaled type of medicine. Unfortunately for this patient, he gained some abdominal weight, which was all fluid, and caused him more shortness of breath, but he referred himself to a GI doctor, thinking that he had a lot of gas. So, and what it was fluid from his heart failure. So that kind of messed everything up for him, but he actually had COPD, and he had right-sided heart failure from the pulmonary hypertension. So he was in hospice, and he passed away at home. So the next slide, please. So his main diagnosis was COPD. So as you can see that none of them are like just one diagnosis. So intrinsic lung disease, COPD, pulmonary fibrosis, and emphysema, these typically cause damage to the lungs, parenchyma, and result in decreased gas exchange, and it can lead to hypoxia and worsening shortness of breath. The CO2 retention can occur, and it's very difficult to treat. Next slide, please. Restrictive lung disease, multiple etiologies include morbid obesity, pulmonary fibrosis, and sarcoidosis. And we do treat patients with sarcoidosis. If it's pulmonary sarcoidosis, we don't treat that. We treat the cardiac sarcoidosis. Next slide, please. Yep, that would be it. I don't know if anybody has any questions.
Well, thank you so much. That was excellent, and it was super informational. We do have time for some questions, you guys. And I know that this is a lot of information to take in. It always is. So if you guys have email questions afterward, you can just let us know, and I'll get those over to Judy as well.
All right, thanks. Everybody have a good day. Great weekend.
Thank you. Everybody, will see you guys again in a couple weeks. And everybody, yeah, I know it's going to be rainy a little bit, but it'll be sunny on Sunday.
And it's a weekend.
Yes.
All right, we'll see you.
Bye. Thank you.
Bye.